these muscles attached to your tailbone. She fell on her tailbone, and she gets pushed down and kind of gets turned sideways.
Oh, I can't do it. I'm thinking that would create a little earthquake action.
Yeah. Lastly, what happens if bone-wise, you guys can go back to your center, I fall off the curb and I get an upslip of my pelvis on one side. You guys all go down, you guys all raise up. Looks like a lot of tension into the pelvic floor, right? So there's a lot of asymmetry that has to happen. The muscles have to be the same length on both sides. They have to be the same strength on both sides. Now what happens if I come in and I do an episiotomy? I cut these, but then I'm going to tie them back together just a little bit tighter. Can you see how that asymmetry is going to cause a huge amount of function on my urethra and how I'm holding my pee in? It's going to cause a huge amount for tailbone and coccyx pain, as well as if my clitoris is doing all this work, do you think she can have any fun? No. Education for this, because we don't get a huge amount within our coursework. And that's kind of what we were hearing from you guys as well. So we had said, what do you want to know about pelvic floor? We heard you know very little to a vast majority based on your schooling, based on what practice you're in. If you're in OBGYN or you're in Urogyn, all of a sudden you have more knowledge base. So today we're going to keep things in layman's terms. We're going to try and give you stuff that's clinically applicable and give you some really good analogies like this. So you can go back to your patients and be using those same analogies from day one. So I'm not going to give a lot of the clinical side of it. It's more going to be how you can use it and apply it to your daily practice. We also asked, what would you like to know about the pelvic floor for your patients? Some of your colleagues said, what is pelvic floor physical therapy? I've never heard of it. Others said, what should patients expect upon referral when we do send them to you? What's going to happen there? And then what patients would benefit the most? And what exactly do you do so we can give patients a little heads up on what you're going to talk about? And then lastly, what should I be asking them about, even to know if they're an appropriate person to come to PT? Is there anything else you guys want to know? I can put it up there. Yes?
Pelvic floor dysfunction after hysterectomy.
Pelvic floor dysfunction after hysterectomy. Can you write that up there, Kim? We'll touch base on that in the first lecture, and if it isn't as clear after that, if you still want more information, just come up afterwards. I'm available for questions. Yeah?
Pelvic floor strengthening after prostatectomy.
Yeah. Pelvic floor strengthening after prostatectomy. You'll see it's a lot less about strengthening and more about the whole components. So touch base with me afterwards as well.
What's the typical length and try to get patients to actually do the full, so if you prescribe 12 weeks of treatment and maybe they need 18 to make them understand that they're going to want
Cool. Our last thing we're going to do is actually how to motivate patients and change, how to get them actually motivated into a place that they will follow through with the prescribed amount of treatment. So we'll touch base on that.
How much lower issues for patients who have chronic issues like cerebral palsy?
We're going to touch base a little bit on chronic pain today. So if you guys missed out on the stress lecture, but little caveat is we have some stress components in here. But we'll talk about that as well. Maybe not specifically with MS and CP, but you can ask me afterwards on that. Any other things? Kim, could you write IC in pelvic floor? We'll talk about the nervous system and how it's related with IC, not specifically about bladder changes within the bladder wall, but feel free to jump in during that time if you have any questions. Anything else? Yes?
sexual dysfunction.
Yeah.
So things that are taboo that people are afraid to talk about, that this can help.
Sexual dysfunction, and we're actually going to spend a fair amount of time figuring out how to help them talk about it through some reflective listening today. Okay. So I'm Jessica. I've been talking about pee and poop and sex for 12 years, 13 years. I would say if I wake up in the morning and I've changed my son's diaper, I've wiped my toddler's butt, my coffee stimulates my bowels, and then I get to go to work and help people poop or not pee and poop, I've had a really good day. I've been graced with being able to go to lots of con ed classes, and then now I'm doing a lot of mentoring in our company for new pelvic floor therapists come in and learn how just to apply physical therapy to their pelvic floor practices. So when I graduated from PT school, the last thing I wanted was to do pelvic floor. I wanted to be an ortho sports therapist. And then I went through all these things that Josh said about alphabet soup, and they came up to me and they said, will you teach exercises for, people that are leaking? It's like, I'm only doing exercise. I will not do evaluation. So that's how I started, right? Let's just give them exercise, but let's not evaluate it. And then what I found out was people were getting so much better, and it actually made a big deal. And my shoulder patients who were like, yeah, I still can't throw the ball with my dog 75 times. I go, well, throw it 70, right? But pelvic floor, all of a sudden you're like, you know what? I was able to go to my friend's house and sleep, and I didn't have to worry about peeing in the bed. That's amazing, right? And so we realized that it's a lot bigger issues that we're dealing with. It affects their social contacts, it affects their marriages, it affects their intimacy, it affects the things they can do, their social and their recreational things. They can't go run or go walk with their friends if they're going to be peeing all the time and have to, wrap a sweater around their waist. That's a big deal to them. And kids, what we found when we're treating them for bedwetting, constipation issues, we actually find that behavioral issues clear up in a large amount of children if the bedwetting or the giggle incontinence or the leakage was actually the way that they were acting out to just kind of mask and say, like, don't look here, look at what I'm doing. And a lot of the behavioral issues are not because of, or the behavior isn't stemming the bowel bladder. The bowel bladder is actually causing them to have some of their behavioral and attention deficit disorders in school. So it's a huge impact, and that's why I do what I do every day. But we all blush about it when we talk, right? And we don't really want to sit too close, because what is she going to talk about for pelvic floor? So here's kind of where we're going today. How many actually take subjective? Do you take the history taking of your patients for your doctors? Yeah, most people. How about referrals? How many people are doing the referrals? About half and half. Good. Well, here's where we're going to go today. I know that these are a little hard for you guys to read up here, but we're going to basically go through, we address the complexity of the lumbopelvic system. We look at this area as a pop can. And so the pelvic floor muscles on the bottom are just one piece of that pop can, but we're going to actually talk about what that pop can is in our next lecture. Then we're going to go through an assessment, an awareness of assessment indicators of disruption of this pop can, episiotomies, labor and delivery, XXX, all the things that might be impacting what the pop can is, and cues that you can be picking up when you're listening to your patients and they're saying, yeah, I have back pain, yeah, I have this, and it's going to tell you, oh wait, think about my pop can, think about my pop can, here's some other questions I can ask. Then we're going to do some reflective listening techniques for the pelvic floor assessment to really get down to the deep part of the discussion with these patients in 2 minutes, right? Because that's about all you have with our busy schedules and trying to keep your doctors on time. So we're going to really try some reflective listening to see if we can tease out them to actually talk about it. Because most of them think this is genetic, this is something I just have to live with, or X, Y, and Z are most important, and all this stuff I can just kind of push by the wayside and not talk about it. Then we're going to talk about different diagnoses that get treated for men, women, and children. We're going to have an awareness of subjective and objective findings about chronic pelvic pain and just chronic pain in general. So even if you're not dealing with pelvis issues, you should be able to take that back to your practice and realize the patients that actually are dealing with chronic pain. And then lastly, we'll get familiar with the interventions of pelvic floor physical therapy, including ultrasound imaging, how we're using that, how we do internal examinations, orthopedic examinations, and biofeedback, which is probably what most people are familiar with pelvic floor physical therapy. And then lastly, we'll do some knowledge on educating physical therapy expectations and treatment and instilling change through that referral. So, where we're going to go next, I want you to take out your handouts. Anybody have to give like little seminars to your coworkers when you get back?
They were all in the front rows.
Yeah. This is meant to be your cheat sheet guide, so when you go back, these are great things. They're the big bullet points for you to say, here's the 5 minutes of presentation that I have to give. So what I want you to do first is take out the one that says 5 S's. The pelvic floor has to do a lot of work. You can see it does the 5 S's, we call it. Sphincteric control, so stopping pee and poop, right? Spine support, it actually plays a role in how it stabilizes our spine. It supports the bladder so that we don't have issues like prolapse and rectoceles. It has sexual function for orgasm, and then it also has some sump pump control for the lymphatics. Your job on the next lecture series is actually just to keep this out, and I want you to write down anything that you hear that could be a disruptor of the pelvic floor pop can. So if you hear me say something, you can just jot it down. You know, if it's back pain, you gotta draw a line by the back. If it's something related to pelvis, draw it there. So by the end, you should have a nice diagram of all the things that are disrupting this pop can or could disrupt this pop can. So this is what matters most. This is my son, Caleb. He's almost 5. He's 8 pounds, 10 ounces when he was born. Henley is my youngest. He's a little over a year. He was 9-1 and a week early. So I went in and said, "Can you please, I'm done." So obviously, practice what you preach. I've had to know a lot about pelvic floor. I was happy to say I went to Sky High, I think it was called, right? This big trampoline place, and I was jumping really hard with my son. I said, "Honey, you should take a picture because this is good marketing, right? I can jump on this trampoline and don't have any issues after grade 3 tear, after giving delivery to 2 big guys." So there they are. So this is the pop can. We have a couple areas of the pop can. So you'll notice there's a diaphragm on top. We have our pelvic floor muscles on bottom, sorry if you guys can't see. And then we have our transverse abdominis, which is kind of like wearing a lumbar corset. He's a back brace built out of muscles. And then we have multifidus in the smaller part of the spine. These are considered my inner core muscles. My outer core muscles are the ones everybody knows about. Those are my six-pack abs. They're my internal obliques, my external obliques, so the ones that do side crunch. And then the big back strap muscles are the longissimus in the back of my spine. These guys, they move me, right? If I want to turn and rotate, they rotate me. If I want to do a crunch, they do a crunch. They're my movers. These are my stabilizers. I do not want my movers stabilizing me. Because if I use my movers to stabilize me and I suck my stomach to my spine, I have nothing to move me, and when they move, they say, "Well, that's my job." So they let go as a stabilizer, and they have to move us, leaving us our spine with nothing to move from. So if you picture this soda can, right? Pop can, soda can, got so many different regions here, right? I'm not sure which one to use. We've got all of those muscles that we talked about, and they also have to coordinate with our breath. So you were asking about post-prostatectomy. Not just doing a pelvic floor Kegel, but if I'm doing a Kegel and I'm holding my breath, guess what? Bladder goes south. So it has to be coordinated. I'm going to breathe in, relax. As I breathe in, my diaphragm drops down, pelvic floor drops down. As I breathe out, pelvic floor comes up, diaphragm comes up. They should be coordinated. They shouldn't be in accordion. So those are the two big. And when these aren't functioning properly, any of these within themselves, then what we have is dysfunction, and that can show in urine leakage, that can show in back pain, and hip pain, and a whole host of other issues. So pop cans are pressurized, right? So you want to keep the pressure on the inside equal to the outside. What happens if you freeze a pop can? That's pregnancy, right? That's obesity or any extra visceral adipose tissue. You add that extra pressure in the system, now all of a sudden diaphragm has to go up, pelvic floor has to go down. When I'm pregnant, my ribs actually move 2 inches up towards my collarbones, so that's why you get numbness, tingling in the hands. People talk about carpal tunnel, they talk about extra swelling, because we don't have a good system in the pop can. Likewise, that's why patients talk about bottom of the pop can, hemorrhoids, if they have any type of pelvic congestion, if they're pregnant, and those types of issues. So we can get pressure. Pressure's going to go where the weakest link is out of this pop can. Now think about if I get a slit in the front of that pop can, right? Everybody know what a diastasis is? Or diastases of the linea alba? About 50% of women, we actually get them. The six-pack abs that you saw in the earlier slide, the fascia actually separates. And you'll see that with your patients when they lift their head up off the table, if you're having them go from lying down to sitting. A lot of times you'll see like this tent right here. It looks like there's this big bulge right in the center. That's a diastasis or diastasis of the linea alba. They've split that. Men can split that as well if they're a big Valsalva maneuver, so they hold their breath to get up. They can split that, as well as if we've had extra adipose tissue in there, that can also split that. So pressure goes out of the weakest link and leaves us unprotected for our back. Let's see where we go here. All right, so this is transverse abdominis. Transverse abdominis is the front of the pop can. And transverse abdominis is this beautiful muscle that when you contract it, it doesn't move, it doesn't do anything, and it gives us stabilization without compression. So I'm not squeezing the center of that pop can is just staying with the equal pressure. This is what transverse abdominis looks like. Oh, I told you I wasn't going to do any anatomy, but I lied. Let's see if we can get there again. Oops. So this is transverse abdominis. You can see it goes all the way up to the ribs. So can you imagine if this split all the way down through here? What we notice is post-pregnancy, a lot of women actually repair down here fairly nicely, but they stay open more up here in the process. So it wraps around, and then it attaches into the fascia of the back. And so it pulls from the fascia, so we can get a lot of back pain if it's not working right. He has to anticipate movement, so when I think about lifting a box, I go to lift something up, it actually contracts before I think about it. And so it has a feed-forward mechanism. If I've had back pain, if I have any type of surgery, C-sections, I've had pregnancy, that will actually shut off, much like if one person is in orthopedics, right? Orthopedics, right, you have an ACL tear or an ACL injury, quad shuts off. It's the same thing. Then that person has to come to PT and we actually have to strengthen their quad back up. This same muscle shuts off to protect the body when there's an injury. So next is the pop can, is the pelvic floor, our favorite one, right? That's the one we all like to talk about. So we can all just do Kegels, right? Post-prostatectomy. So if I address just the bottom of the pop can, what about if I didn't pay attention to the top of the pop can? If they were still holding their breath with their diaphragm, or if they were pulling their belly button in too much to their spine, all of a sudden this pop can, the pelvic floor gets a lot of wrap, but it's actually just the bottom piece of the pelvic floor. So that's where PT comes in. You know, if you go for an ACL repair, if you didn't get sent to PT, it would be malpractice, right? If you didn't have PT after an ACL. Yet we have traumas to the pelvis, we have pregnancies, we have hysterectomies, we have all kinds of surgical procedures, and yet that referral doesn't always happen because we have to rehab these muscles the same way that we do in any of our other muscles. So this is the pelvic floor. That's what you guys created down there. You can see it's all muscle through here, right? Because a baby has to come out of there at some point, or not, but baby can come out of there. We have lots of muscles that attach to the tailbone that we talked about, and then we have a lot of muscles that come up and attach to the clitoral hood and onto the pubic bones. You can see that these muscles are like a figure 8, and then they're like a triangle. So if I do an episiotomy through here, you can see there's a huge amount of muscular activity there. All those muscles are coming together at the same point. So one important thing we can do in PT is we actually teach people how to deliver a baby. So I want you to just try something. I want you to pull your belly button to your spine. Did your rectum open or close? Closed. So if you pull your belly button to your spine and your rectum closes, what do you think is going to happen to these muscles when you push the baby out? You're going to tear. Likewise, if you are having problems with constipation or you have a child who can't have bowel movement, if that is closing, that's going to hurt. So now all of a sudden we have a kid who has painful bowel movements, who starts getting constipated, who starts having to go on Miralax, and then it's painful every time. Now all of a sudden you see it keeps going and going and going, and all of a sudden it's painful. So what we do is teach them how to poop or teach them how to have a baby. Now try this. Everybody put your hand on your belly. Breathe into your belly. As your breath is full, hold your breath, bear down, but don't pull your belly back into your spine. Did your rectum open or close? Open. That is how you're supposed to poop every morning. And make sure you lean forward. For some people. So this is what we can do. We also use biofeedback. There are little electrical sensors They go on the outside, right next to the rectum, so you can see right here, I can put sensors right in through here, and we actually can tell when the muscle contracts and relaxes. Kids get to play a little video game, which they think is pretty cool. We have some sensors that insert vaginally and insert anally as well, where people can feel the pressure and feel the contraction. It's almost like squeezing around a tampon. We tend to use those less often because insurance doesn't pay for them, and we can get just as much feedback from the external and then from doing the internal exam. So here's our pelvic floor model. We talked already about how things can be going down on the pop can if we're holding our breath. We talked about if things can be going outward on that. COPD is another one. If somebody isn't breathing right, you can guarantee that they might have incontinence issues because now all of a sudden they can't control the top of that pop can compared to the bottom. Likewise, we say weight gain. 5 pounds of visceral is 50 pounds on your pelvic floor. So if you want to tell your patients anything they can do, you say, you know what? Even 5 pounds, well, just think of a sack of potatoes, right? If I have to carry around a sack of potatoes, how do you even take 5 pounds away? That's 50 pounds. That can really help with their incontinence issues if they're having leakage. So here's the diaphragm. Diaphragm lives up on the top. I have to tell you, these pictures are all, it's probably hard for you to see, but they all came from 3D Essential Anatomy 5. These guys are gracious enough to let us use all these in their presentation. They have an app that's about $33. You can create whatever slides you want. It's great for patient ed and great just for your own learning. So you can put different systems on, peel different systems off. So I really liked using them. But the diaphragm is good for colon motility. So you think about that diaphragm moving up and down. It's actually pumping on your colon, which helps motility, which helps for people with constipation. And good breathing patterns really help us to reduce our central nervous system. So when we talk about chronic pelvic pain patients, and we talk about patients who have more anxiety, they tend to be shallow breathers, and that then keeps stimulating our central nervous system. So we're going to talk about a little bit about IBS and pelvic floor pain patterns. Breathing becomes one of their most essential treatments that they get. So then there's the back of the pop can. That's multifidus. Multifidus is a little muscle that he goes from, these are my vertebrae, right? And he goes from one vertebrae and goes 2 vertebrae up. So he goes from the spinous process of 1 up 2 vertebrae, spinous process of 1 up 2 vertebrae. So he's kind of like feathers. He acts like a horse rein, so if I pull 2 of them back, he stabilizes my back when I have to bend forward. The patient might have multifidus issues, might go down to tie their shoes, and you're going to see them, and they do this to get back up, right? Or another patient might come in and they might say, you know what? Every single time I vacuum or do anything in rotation, I hurt. I get back pain afterwards. They might have issues with the multifidus doing one side versus the other. So if you think about horse reins, it has to control when I go into rotation. So those are some cues that those patients might be talking about. Our global stabilizers. Now remember, those were our local ones. These are global ones. Global ones are the ones that are our movers. Our big back strap muscle here, he goes from vertebrae to vertebrae, but he goes from here all the way down. So if you think about if I stacked up 5 books and I wanted to walk around, I would compress them and I'd hope that I didn't tip them over, correct? So we get stability from these guys, but it's with the result of compression. So compression over long periods of time. These are your patients who might complain of SI joint pain. You're like, oh, I just always hurt in my SI. Well, if I'm compressing all day long, those joints are going to eventually hurt. So they're a perfect example of those. Here's my 6-pack abs, like we talked about. Everybody knows them, right? Internal obliques, external obliques. And this little guy is interesting because he's a hip muscle. So this is obturator internus. Hip dysfunction often coincides with pelvic floor issues. So our pelvic floor muscles attach actually to a little ligament right here. It's the only place in our body that muscle attaches to a ligament, not muscle to a bone, right? When I have my biceps, it attaches to a bone, attaches to a bone. That's great, it has some good stabilizers. All of our pelvic floor muscles right here, you can see, they come up and attach onto another muscle. It's not a very good design. So patient who comes in and says, I have greater trochanteric bursitis, I have hip pain, I have piriformis syndrome, all of those things tell you there's something wrong with their hip. Great person to ask, do you have pelvic floor issues? And we'll talk about how to do that. So we've talked a lot about muscles, but there's a lot of nerves down there. This is just one little example. Do you see all those nerves? Those nerves can get pushed on, they can get damaged during delivery. If I'm sitting for prolonged periods of time, they can cause issues. If I'm sitting on a bicycle seat, they can cause issues. Any type of surgery can actually cause some damage to those. So we actually check and make sure sensation looks the same in the pelvis, on side to side in each area. And each muscle is supplied by a different nerve. So when we do our testing, we say, okay, is this muscle the same as this one? Is this one the same as this one? So we can actually figure out if these muscles, if maybe the nerve is actually the cause of it as opposed to the muscles. So that's one of the things we do for our exam. The central perineal body. It's the cruciform of where every single muscle attaches to. So when you think about deliveries, when you think about episiotomies, this area is really crucial. If he's too tight, right, that's going to close this opening and close this opening. I'm going to have constipation, I'm going to have pain with intercourse, I'm going to have pain with tampons, I'm going to have all kinds of maybe difficulty in urination. Likewise, if this muscle has relaxed too much, guess what? I'm going to have prolapse because this vaginal opening is bigger. Now things can start to fall out of that center section. So he's a really important part for us. I always say it's kind of like holding Atlas up on the shoulders. He has to hold the world up on his shoulders all day. So there's basically three kinds of pop cans. If you want to think about your patients as they start to come in, we can have slits on the pop can. So surgeries, C-sections, episiotomies, hernias. We can have the suck it in pop can. That's your, I'm a triathlete and I work out 50 miles a day and I hold my core tight because somebody told me to hold my core tight all the time. And my Pilates instructor tells me to hold my core tight every single time I'm in class. And when I'm in yoga, they tell me to do my Mula Bandha, which is my yoga pelvic floor, and I'm just holding it all day, every day, right? They do that, and that contracts and pulls in. Think about squeezing that pop can. And then there's the what pop can? I haven't worked these muscles in years. My muscles aren't very strong. I'm just generally deconditioned. So there's three different types of pop cans for you to start to cue in on for your patients. So here's the diastasis. This is what I was talking about, that six-pack ab muscles. You can see how that stretches. So there's a small line here, much bigger line here, and we usually repair back about to this. We actually don't have a lot of great research on this. It's just starting to come out, but we are starting to learn what some norms are. But we do know transverse abdominis helps this, and we have a huge amount of research on transverse abdominis. So transverse abdominis is the muscle that we're doing to try and get that load across there and try and transfer the load so that they don't have back pain. So the pop can always gives rise to the weakest link. If you've had any disruption of these, then it probably means if it's not working in one, it's probably not working in another. So when you're talking to your patients, and your patient says, yeah, I have a lot of back pain, there's back pain here, support spine, I have a lot of back pain, now you have a way to say, you know, those muscles have to do a lot during the day. Not only do they have to work with back pain, they have to support your bladder. Do you have any issues with that? Now you have a lead-in to be able to ask them without just going, do you leak on a regular basis? If I've had any one of these disruptions will actually cause slits in the pop can. So that's disc herniation, hemorrhoids, episiotomy, C-sections, pelvic lacerations during delivery, abdominal hernias, previous abdominal or back surgery, scoliosis, and even TMJ. So I talk about the diaphragm. The diaphragm is the top of the pop can. They actually have shown that the glottis is the top of the pop can. And so they show that most people who have TMJ dysfunction also have pelvic floor dysfunction and vice versa. So we know that if someone has drop pain, we should ask about pelvic floor as well. So we already talked about sucking it in, right? Sucking it in isn't the same as turning on our core. When I suck it in, I actually use my six-pack abs and my oblique muscles, and it leaves me with the pooch. You know, some women will come in and will say, I just can't get rid of this down here. My abs up here okay, but I just can't get rid of this. That's actually because the obliques are holding tight, and then they don't have any of the transverse working to help hold this in. Transverse's job is actually to hold this in. So that's another example of something that you might see or a patient might talk about when they come in and say, hey, I'm just not sure what's happening here. You're excited over there. We better liven up, huh? So too much compression, we talked about SI joint pain, constipation. They might have pain with intercourse, pain with tampons and entry, difficulty urinating, and they need a junior size speculum on exam. Yes? Yes. Also constipation issues, because if they don't have the breathing patterns and their diaphragm isn't getting utilized, now all of a sudden they're not going to be pumping the colon the same way. So, yeah. Same thing would be for anybody who has huge amounts of stiffening in the spine, any type of RA, OA, those types of things in the spine. So anybody setting up for exams, and if that patient's chart says needs small speculum, can't accommodate adult size speculum, that's a great example of somebody who probably needs some type of pelvic floor work. And IBS and abdominal pain. Our back pain patients, the wet pot cans, they all have back pain, they may have SI joint pain. They're the patients who say, oh yeah, I go to the chiropractor 20 times a year. Oh yeah, my back feels fine as long as I just have it adjusted every now and again. My husband's gotten so good, he can do it now. Because they don't have enough muscle support to hold the spine where we need it. Remember our spine over here, they keep getting the upslip. They get the downslip, okay, then it's fine, or they get some type of manipulation and things go around for a while, but they don't have the muscles coordinated around the system. They also feel better with bracing and taping. So it's a patient that you might actually see come in with a brace or taping on their back. They wear some type of back brace or a girdle, that helps them to get some stability. They're a patient who tells you their back pain feels better when they're pregnant. Why is that? Pressure. They've added some pressure into the pop can, so now they feel better. They're like, yeah, my back pain went away. I love being pregnant. Guess what's going to happen after baby? Now all of a sudden they lose that. Their hula hoop is still out to here. They've lost baby, and they still have pain, or their pain returns, and even worse usually, because then they have some other disruptions. There are also patients who have reduced activity level. They're the has-beens and used-tos. I used to go run a 5K. I used to go do this. I used to go do that, but now they don't do it because of something else in the system is probably bigger. They don't go work out with their friends because every time they get leakage, so they have to tie their thing around and wear black pants and hope that they don't have any leakage when they're out with their friends and going for a walk. The pain after day of activity, that means we've caused inflammation into the system. If I go down and I bend to pick something up and it hurts, that's mechanical. That's something's happening in my spine as I'm moving. If I go out and I can weed my yard for 2 hours, and then I get home that night and I sit and I rest and I wake up the next day and I can't move, it's because I caused inflammation into the system just because these muscles weren't controlling on a regular basis. They're a patient who might have a high Beighton scale. Anybody know what Beighton's is? Beighton's, yeah. Beighton's is a laxity scale. It tells us how loosey-goosey the collagen in our ligaments is. So it's a 9-point scale. They're the patients who can put their hands flat on the ground and touch their hands flat without bending their knees. They'll have hyperextended elbows, hyperextended knees. They'll be able to take their thumb and bring it back to their forearm. And then they'll be able to take this finger back past 90. So we count those 1, 2, 3, 4. Double that on the other side, and then hands on the ground is 9. Anybody who has more than 5 is actually more loosey-goosey or has more laxity. And then successful weight loss program. Somebody who just says, yeah, I just lost 75 pounds and my back is killing me now, right? They lost some stuff out of the system, so now the system isn't able to work. We're losing things left and right. All right, so that's the longest lecture you guys have to sit through, I promise. You are going to turn to the person on your right, and I want you guys to take 2 minutes to discuss what did you guys hear that are things you might objectively see with your patient. that could just be a signal of disruption. I'll give you one example. You see the tenting of the diastasis when they lift their head up. Okay, so pretty new to everybody else. Motivational interviewing is actually a style that guides the motivation. It's what you choose to reflect on, helps you to guide them what to talk about next. If there's nothing else that you guys get out of today, it's whatever they talk about, you choose between those things about what to talk about next. If she's talking about running while leaking, you can either choose to talk about running or you can choose to talk about leaking, but you've just steered the conversation into two entirely different places. And then it's hard to get back to get the objective or subjective information from them if you've taken them down a different rabbit hole. It's a language to help them talk about their health. It creates a space for them to talk about it and how it impacts their life. We can deal with pelvic floor issues for a really long time and put them under the rug, so we can wear a pad, we can kind of disguise it, we can hide it. Pain will get us motivated to do things, but this stuff doesn't. So unless it's impacting their relationships and you can figure out how to point them to that, they may not want to address it. So that'll help with the compliancy and getting them to stick for the 6 to 8 weeks. Now we're going to watch another video using directed motivational interviewing. Notice the open-ended questions she asks, how she acknowledges the patient with her body language, and how she acknowledges and repeats back to the patient in general.
Hi, Brina. Hey. So I see you're here for back pain today.
Yeah, unfortunately.
Yeah. I also see, that you had 2 children. So one vaginal delivery and one C-section.
Yes.
Yeah, and you had some tearing with the vaginal delivery. Yeah, I was wondering if I could ask you a couple more questions about that. Sure. Okay. Do you ever have any leakage of urine with coughing and sneezing?
What else? And all of a sudden they start diving deeper. I read that, I was like, oh wow, he's got a good thing. He also suggested making sure that, you know, their wine is full, that there's food, you know, so that they can just keep talking and they don't have to worry about their physical needs. And I thought, that's a great point. When you have a patient who's really diving deep into things, maybe they're talking, maybe they're crying because this is emotional, make sure you're tending to those physical needs. Make sure you've got tissues there, you're handing them that tissue so that they don't shut down because they're looking, where can I find a tissue? Or this is embarrassing, I don't want to talk about it. So I actually thought it was a good point to bring up. So all of this stuff comes, I saw only a couple of local people here, but Dana Surveillance is an amazing instructor here in town. She runs Be Nourished Institute, and it's where I got some of my motivational interviewing coaching from. And so, but for anybody out there, they have a lot of motivational interviewing classes now for all kinds of allied health providers. So if this stuff interests you, I'd check out motivational interviewing, or Brené Brown is another psychologist who's done a lot of work in this area. So check those places out for that. One of the most important things, oops, I'm going back here, that we can do after we're done with this is when we walk out of the room, I gave you guys a little cheat sheet called Reflection in the Rearview Mirror. This stuff takes practice. It's not easy to do, but this is just a little reflection piece that as you're walking to your next patient or you're walking to the charging station if you have to go somewhere else or running in there because you're running late. These are 5 questions you can ask yourself to see if you could do better the next time. Number 1 is who did more of the talking? So they say that patients actually, we should be about 70-30 or about 2-to-1 ratio in terms of how often we're asking those reflective listening questions to them. Did it feel like a wrestling match or a dance? Did I feel like I was following their move, or was I trying to wrestle and like get my point across because I already had a preconceived agenda of what I was going to try and tell them? So that's one question you can ask. How much information did I share? There's actually some research that says only 17% of patients care about anything about you. That it is actually more detrimental to their healthcare for us to share any information about ourselves. Even in the pelvic floor world, I tend to not share something. If they ask me, well, have you had 2 babies, or have you had any of this? I'll say, would it matter? Would it matter if you knew that I had gone through that? Same thing, if somebody's an alcoholic and they're trying to go through recovery and you're trying to get them to change for that, would it matter? Would it change if you knew what I was going to tell you about myself? If it's big, yeah, then maybe they really should hear that information, but it usually does nothing to help them, to motivate them to change. What was one thing that was well, and one thing that could go back and do differently? So those are just some points you can brush yourself up on. On this side, if you really want to get into this, there's an 11-point checklist if you have time for that. So I put that on there as well. So you guys, how many people wish they were over at stress and talking about stress and chronic pain and said, man, I can't believe I have to sit through 2 hours of pelvic floor lecture, right? No? Good? Well, guess what? Little thing, I put in stress for you guys. Chronic pain is a huge amount of peace. So you get the best of both worlds, but don't tell them. So men, we haven't talked much about guys yet, right? We've talked a little bit on post-prostatectomy. I will tell you there is as many men with chronic pelvic pain as there are women. They just don't talk about it. And they find my office because they Google testicular cancer, they go, ooh, pain down there, and all of a sudden they find out that they figure out it could be muscle. And they walk into my office scared to death thinking, this is cancer, this is something big, bad, and ugly, and they realize that it's muscle dysfunction. Or they go to the urologist, and the urologist is smart enough to know and says, hey, you know what, this is chronic non-bacterial prostatitis, this is, bless you, this is pelvic floor, and you should go see a pelvic floor therapist. So chronic pain is a huge piece. There's a little secret about chronic pain, and I'm gonna go, let's see, handout. You guys have a handout, another cheat sheet for you guys to fill out while we're talking so you don't fall asleep during the lecture, right? And it says, why does it hurt down there? Do you have that one? Yep. Yep. Why does it hurt down there? I have listed most of the things that we're going to talk about why it hurts down there. So you can follow around, you can write some notes on each one of those. I also left an open bubble that says what else, because sometimes there's something else that the patients have to talk about that could be a piece of their chronic pain. So we all know if we stepped on a rusted nail, you want to know about it, right? You step on the nail, the nerves in your foot send the signal to your brain and says you have pain so that you can go get a tetanus shot, you can get the rusted nail out of your foot, and you can tend to it. That's a great thing. Your nervous system is working for you. Now what happens? After that, you take the nail out, a couple days later it feels better, right? It takes some time, but eventually that nervous system calms down. We have 400 individual nerves in our body. They're all connected, there's 45 miles of them, and they're connected like a superhighway. They talk to each other up and down and over. That's why I say the gut is gossipy. When someone has pelvic pain, they usually have IBS, they usually have urgency, they usually have all kinds of issues, they might be stressed out, they might be having issues with their family. The gut, when you have a gut instinct, where do you feel it? You feel it here, right? And so that nervous system really starts to get ramped up, and it talks along those nerves. Our nerves always have a resting tone. So you can see here, this is the resting potential of a nerve. I step on the nail, the alarm goes off in my body, and then eventually it comes back down and it goes back to baseline. In 1 in 4 people, baseline does not come back down. Baseline lives up here. So now, if I have a baseline that lives up here, and I'm a patient who had chronic pain issues, anything going over 3 months is considered chronic pain. If I am one of those people that baseline is right here, how much activity do I have to do before my nerves start getting excited? Now all of a sudden this is the patient who can't go for more than 10 or 15 minutes. They say, man, I used to be able to do that for an hour. Now I can do 30 minutes of activity and I'm flared up for 2 to 3 days and I can't come back down and I don't know why. So their nervous system has given them less wiggle room in order to come back to the same place. I like to use the analogy with patients that your nervous system is kind of like the alarm on your house. You want your alarm to go off. If a burglar is walking through or going through your window, there we go, going through your window, you want your alarm to go off. If a leaf blows by, you don't want your alarm to go off. You'd be driving your neighbors and yourself crazy, right? And that's the same thing that happens with chronic pain and chronic pelvic pain. Is anything, now all of a sudden my tailbone patients, they can sit 4 minutes. They've had pain for 5 years, and they can sit 4 minutes, or 2 minutes, or 3 minutes. There's nothing wrong with their tailbone. But the pain system, they sit for a very short period of time. It's like a leaf blowing, and it sets everything off for a long period of time after that. So I use that analogy just so that they realize we just want their nervous system to get a little less sensitive. There are a lot of things that can cause chronic pain. One of those things is just ongoing pain, like I mentioned, greater than 3 months. Fear and anxiety, so, you have pain down here, that's a big deal. Is that bladder cancer? Is it testicular cancer? Your brain starts to go with these things and starts to say, what else is going on? The more I get nervous about something, my nervous system will do exactly what I want it to do. It will run away from a danger or a threat, right? Barbarically, that's what our nervous system is designed for. If there's a lion chasing me, I better pump all my blood flow to my arms and legs, all of it away from my stomach and my colon. Who cares if I digest my lunch? I need the blood flow to my arms and legs so I can run away from the danger. If I'm nervous about it, if I have fear about it, if I have anxiety about it, my nervous system's going to do the same thing. Panic attacks are what, for a lot of people, it's asking them to have their nervous system do exactly what they want it to, right? They get anxious about something, the heart rate beats faster, they get a higher blood pressure. All of that's happening because we want the nervous system to do it. Family concerns, a lot of our patients will come in, I just went through a divorce, I just had this happen, I'm taking care of my elderly mother, I have all of these stressors, and I have to deal with this, and the pain keeps getting worse. Failed treatment. These people have been to see everybody. They've seen urologists, they've seen gynecologists, they've seen massage therapists, they've seen acupuncturists, they've seen naturopaths. They are researching to find what is wrong with them, and they have a slew of providers that they are trying to get on board, and every single provider has failed them. And every fail that they have increases their nervous system. Oh, that didn't work either. Oh, that didn't work either. Oh, that didn't work either. All of a sudden now that pain is getting more and more and helps elevate their system. Job issues, and then different explanations. Their urologist tells them it's something, their PT tells them it's something else. Dr. Google, who must be right, tells them something different, right? Or Dr. Google tells everything may lead to death. So all of those things start to amplify. When my patients come in chronic pelvic pain, I tell them the first thing they have to commit to, you cannot Google anything. If you have a question, you write it down and you bring it to your next appointment. If you have to get it off your chest, you email it to me and I will print it and I will put it in your chart and we'll talk about it next time. But you are not allowed to do Dr. Google because Dr. Google tells them everything is big, bad, and ugly. So your alarm goes off, right? How long has your alarm been going off? If someone's alarm has been going off for 5 years, that's how long their pain's been present. Vice versa, right? 5 years of pain. Alarm system's been going off for a really long time, and that's been going off every day. If my alarm goes off at 11 o'clock at night, my neighbors are going to come out and they're going to say, what's going on? Are you okay, Jess? And then they're going to want to go back into bed and go to sleep. But now what happens if your alarm keeps going off over and over and over and over? What's that? You're that neighbor. So if you're that neighbor, guess what? The cops are eventually going to come. And they're going to scope out the area. And it's the same thing in patients' bodies. The alarm will go off, and the body is actually going to go through and scan all the old crime scenes. So all of a sudden, they just had a new knee injury, but they're a chronic pain patient. They come in and they're like, yeah, my foot is flared up, and that old shoulder rotator cuff, that hurts too now, and now I've got this pain, and this one's back, and I got treated for sciatica, and that hurt, and now this is flared up too. Of course, because remember that picture of 45 miles of nerves? All those nerves light back up. There's nothing wrong with their shoulder that they had recovered successfully earlier, and there's nothing wrong with their sciatic. It's just everything comes to the table. So that's a great subjective of those patients who just keep saying, and this, and this, and this, and this. They might be an example of somebody who's chronic pain. So how do we calm down the nerves? This is where PTs come in. So we know that the answer is pain education. PTs are really advanced in educating patients on pain, whether that be chronic pelvic pain or regular pain in itself. And we know that getting them moving, what we call safe but sore and hurt doesn't equal harm. They've shown on x-rays and images that somebody can have bone-on-bone osteoarthritis, they can have huge amounts of labral tears, and guess what? After a while, it doesn't hurt. After 6 months of having a disc herniation, those patients will not have pain, no more than somebody else who doesn't have a disc herniation. 50% of people walking around. So if I take 100 people, 50% of them have disc herniations in their back and they have no idea. So why are they pain-free and the other one's painful? A lot of it can be because of the nervous system input. So we know how to educate them on how to do that and how to get them to get some wiggle room from here. This is not an example of one exactly from pain, but they have done some fMRI studies. Thank you. They've done some fMRI studies where they've shown all the areas that light up in the brain when someone has pain, and they go through the same 30-minute one-on-one, which they found is more beneficial than group, one-on-one education about pain, and half of the brain lights up after pain, just after 30 minutes of education. There's some great explain pain. If you Google explain pain on YouTube, there's some great little 12-minute, you know the little white drawings with the black pictures? Everybody know what I'm talking about? They kind of move and talk at the same time. There's one on explain pain. It's a great little intro for patients to understand. Yeah, I don't actually let them do it at home. I make them do it in the office. I bring the iPad in and I say, here, you get to watch this while they're on heat and working on deep breathing. So no Dr. Google. I don't let them go home and do it. So the other thing that we know, and something for patients for you guys to consider, is the average chronic pain patient, guess what their beats per minute of their heart rate is? That's not the answer, by the way. 85. So all of a sudden you're taking blood pressure, your patient's saying, and this hurts, and this hurts, and this hurts. At rest, they're at 85 beats per minute. In PT, we know we only have to get them to 100 beats per minute exercising to see that threshold drop down. That's not very much activity. So we actually set up when we graduate their activity for them, we say, you know what, you're going to do 2 to 3 minutes of walking 4 to 5 times a day. And we'll give them the parameters, and we'll set it and move that dial just a little bit. I always tell them you want to nudge it, you want to kind of tease it, you want to get into the pain threshold, but you don't want to blow through the roof. If they're a chronic pain patient who goes out and does 6 miles of walking, their body's going to say, you didn't listen to me. So then they'll take that threshold, and they're going to drop that threshold. That threshold is going to go a little higher. Now they have even less wiggle room. So, and that's a common thing that chronic pain patients do, is they just try and say, I'm tough, I can live through it. I'm tough, I can live through it. When in fact, they're just making their wiggle room less and less and less. So we try and take them through that piece. We even divide up tasks. You know, I'll have patients come in and I say, what's the one thing that you would like to be able to do? And they're like, vacuum my house. I can't do it. I mean, my tailbone will set on fire, and then I'm laying on my side for 5 days afterwards. It just destroys me. And so we take and we say, okay, let's map it out. Let's do this part of your house first. Tomorrow you're going to do this section of your house. Tomorrow you're going to do this. Oh, you got to make dinner for the family. You're going to cut up the veggies at 9, and then you're going to do this at 10:30, and so that they can actually be successful with some of these activities because they are not able to function with a lot of them. And back on that, if you're talking to chronic pain patients, one of the biggest things that they can do is get in a group with activity. We have found that in over anything at all, diet and stress and all of the above things, actually them having socialization is one of the best things that can help chronic pain. 5 social contacts is what is needed a day. So Kim, which thank you by the way for all you've done today, is our office manager. And Kim and her front desk, they know that if it's a chronic pain patient, every single one of them are going to try and chat with that patient for a few minutes, because now they've gotten one conversation on the front side, they've gotten to talk to me, they've gotten to talk to my assistant, they get one on the back side. That's 4 right there. They get 4 socializations just from coming into the office. I tell these patients, hey, stop at Starbucks when you're there and actually talk to the person who's checking you out for a minute or 2. Wave to somebody when you're walking down the street. Just trying to get some of that socialization, because that has gone away in their lives. Yeah, they're able to build up, and we give them modifications of saying, you know, if the pain's there longer than an hour afterwards, that's the perfect amount of activity to do. If you wake up the next day and it's even more still painful, then that was too much activity. So there's, we give them graduations of that. The brain is pretty darn impressive. It does a neurotagging of pain is what they found. And so if everybody thinks about their grandma, you all can think about the way your grandma smelt, maybe the way she moved, maybe the way she talked, maybe the way she had some certain type of mannerisms. Because our brain uses all of those areas to say, this is grandma. Well, the same thing happens with pain, is it uses different parts of all parts of the brain. And so those are the patients who come in and they say, I just can't remember as much, I just, this isn't happening, this isn't working, I just, I'm feeling fatigued all the time, I'm feeling kind of foggy. It's because their brain is tied up in a pain medium. Their brain is functioning, so it doesn't have the other functions for these types of things. On your handout, you'll see on there that their sleep is disturbed, and a lot of times that's also because of their pain being busy, or their brain being busy because of the pain. We talked a little bit about the lion, right? The lion is like a big, roaring African lion chasing after them, and their pain is that every single day. And so from the moment they wake, that lion is in their life, and some of their bodily systems kind of have to ramp up to protect them. One thing you'll notice when they walk into your office is you ask them to take blood pressure. Right? They're the patient, it takes them on average 4.5 seconds to decipher right to left. It takes you and I an average of 2 seconds to do that. So if you are seeing that combined with an 85 beat per minute blood pressure and a subjective that says, and I have this pain and this pain and this pain, there now all of a sudden you've got the information to present to your doctor to say, maybe chronic pain is a piece of this, because these are some of the findings that I'm finding. This is the homunculus in the brain. Everybody familiar with that? The homunculus? Fun name, right? So the homunculus is where they've actually mapped out on the different parts of the brain where we have areas for each organ. So you can see there's the foot, here's the foot, you can see here's the hand, here's their intra-abdominal areas. And so each area is very specific on where it's at. What they found with patients who have chronic pain, this area gets blurred, it gets smudged. So the brain can't decipher right versus left as quickly. The brain has a more difficult time with that. And so our job is to actually get that back and get that sharpened. And so we do exercises with chronic pain patients, and I don't tell them to do 10 hip lifts because I'm not doing the brain a favor. I say, okay, do 2 on the right. Okay, now do 1 on the left. Okay, now tap over here. Now do over here. So I challenge their system to really have to focus right and left so that their system is always having to try and think, is this right brain versus left brain? And these are the nerves. You can see there's a ton of them. Like I said earlier, the gut is gossipy. And so getting their nervous system to calm down, we do that a lot by deep breathing. We do that a lot by meditating, and giving them some practices that way. Teaching them how to relax their pelvic floor, because most of them are holding their pelvic floor up in their ears. And if your pelvic floor is up in your ears like this, it is not going to function for them. And it's going to become painful. It's been there for a long time. A lot of times these patients actually need us to go in and stretch the muscles so that the muscles are coming down so that the muscles can relax. Because when I've held those muscles that long, they get structurally shortened after a long period of time. So you'll see in your handouts or in your folder, this is just an example of our prescription pad. And on it is every diagnosis you could possibly think of. That's because some of our docs really like just check boxes so that they don't have to write it. And it also is just a good example to say, hey, this is a reminder that they do treat this as pelvic floor physical therapy, because sometimes they don't know what we treat. Now, if you fill these out, I will tell you, eval and treat is fine. If you don't know what to pick and your doctor doesn't know what to pick, you guys are just going, hey, this sounds something like the pop can. All you have to do is basically put up on the top eval and treat. Time-wise, you'd ask how many sessions, right? Medicare requires us to do some things every 30 days. So I would tell people just write 2 times a week for 4 weeks, or 2 times a week for 12 weeks, or 2 times a week for whatever. And the PT will send their eval back to you saying what they really think that patient needs. Some of them only need once a month, some need once every other week. So if you just write a blanket statement in there, that's usually fine as well. But feel free to use that in your practices or morph it in whatever you want. So there's lots of different kinds of incontinence. We have stress incontinence, which is cough, sneeze, lift, change with activity. We have urge, like I talked about, which is greater than 6 to 8 times a day or more than once at night. And just really, like I said, not worrying about what you pick on those, but if you just write incontinence, that is fine by that. So what to expect? I'm telling patients, you should go to PT, right? You should expect that most PTs, we do a 60-minute eval. Sometimes with a complex pelvic floor case, I might take 30 to 45 minutes for subjection. I listen to their entire history, back to the hip issue when it was 12, and the C-section when it was this. They get the opportunity to give us all that information. So sometimes it's 30 to 45 minutes. And if we feel like psychology or cognitive-based therapy is better, we'll actually refer them back to your office and say, they're not a great fit for PT right now. Maybe they should go see an adjunct facility first and then come back to us afterwards. You need to find a PT that is good orthopedically. You can remember how we talked about these bones, right? If there's an upslip of those bones, no matter how much I treat the pelvic floor, that's going to be the same issue in terms of needing to have good manual therapy skills. They can't just be a pelvic floor provider. And likewise, pelvic floor training, like you guys, we don't get a lot of it. So really making sure that you're finding somebody who has a huge amount of extensive training in it. So they actually have training in internal examination, both intrarectally and intravaginally. You wouldn't take your knee to the orthopedic doc and have somebody not doing any knee testing, right? You wouldn't take your car to the car mechanic and not have to do any testing and prescribe just Kegels. So making sure that you find somebody who has that extensive knowledge, or at least has some colleagues that they can refer out to if they don't. So we are up on time. I have like 2 more slides. Are you guys still okay to hang out?
Yeah.
You guys are good? I have 5 more slides. Educate for their tools on their toolbox. So we'll do a lot of education. Pediatrics, I told you about their bowel movements. Urgency, we'll teach them some stuff. And then we'll really teach them you have to make enough room in the house, right? If you're constipated, you're gonna leak urine. So we have to clear up constipation before we can deal with any type of bowel, any of the bladder issues. The last thing we do is we use real-time ultrasound to actually visualize the pop can. I can see someone's diastasis. Finger measurements are not reliable. And I can see their core muscles. I can see the way they work when they lift the leg, when they lift the hip. So I try and actually visualize what the transverse abdominis is doing, as well as the back muscles. I can do pre- and post-void residuals, and then I can see the pelvic floor muscles on the bottom and how they impart on the pelvic floor, whether they're creating a good bladder neck and whether they're actually holding the bladder where it should be. So we use ultrasound a lot for those things. And there's a picture of biofeedback, and we talked a little bit about that before. So the last piece for you guys is just when you talk to your patients, one of the biggest things you can ask them to motivate change is a disarming question. Rather than saying, why should I see PT? Why should you do stress incontinence? Ask the opposite. What would be the advantage to not addressing your incontinence? What would be the advantage to not addressing your sexual function? Now all of a sudden they're going to say, well, my relationship would probably get destroyed because we can't have intercourse because of this, and that's going to have long-term impact. This question will probably tease out to them more than anything else to get them to motivate change. Some other cues you can use are research shows physical therapy has helped. Some of my patients say physical therapy has been beneficial. What we generally recommend is, and these 3 cues will help patients so they're not defensive and so they don't have to shut down when we're talking about trying to motivate change. That being whether it be incontinence, whether it be change in alcohol habits, those types of things. These are good questions for recommendations to them. So that's us. If you have any questions, that's my email.